123，123，試聲，123，hello，hello，123，試聲，123。123，123，O 唔 OK？123，123，得唔得？喂，得唔得？OK 好，拜拜。
Good afternoon, or I should say early good evening. Ladies and gentlemen, my name is Samson See. This evening, I am acting as the moderator for the session, but also on behalf of the Dean, Professor William Haywood, I am wanting to welcome you and also to extend a very, very warm welcome to our speaker, Professor Bill Mueller, or William Mueller. This evening, we titled this meeting as a distinguished lecture. I have to say the distinguishedness is not to do with the room or, of course, not the moderator. The distinguishedness goes to our speaker. What we are going to do is I would like to invite Professor Mueller and come forward, and we will take a quick photo before we start the lecture this evening. Thank you. What we are going to do is perhaps before I introduce the speaker, I have put up this kind of thing. And what I would like to invite you to do is to log in, go to www.slido.com. One time you are enjoying, you're listening to the lecture, but at the same time, you may have questions you'd like to raise at the later part of this lecture. You can do two things. One is ask the question you like to ask, or you can vote the question you like. And we will look at the popularity voting, and those questions may get to be asked as well. Well, for tonight, the plan is Professor Mueller will speak for about 55 minutes, and make sure we'll have a good time for some dialogues and questions as well. Approximately, we plan to finish tonight's lecture at about 7:15. To make sure you have time to perhaps talk to Bill individually, or in some cases, maybe some photo time as well. Because I think we are very obsessed with photo taking. It's a good national sport, I think. Professor Mueller, perhaps I really don't need to say too much as far as introduction. To the extent I bought the book myself, okay? And I got the signature already, the good thing. Professor Mueller is Emeritus Distinguished Professor of Psychology and Psychiatry at the University of New Mexico, where he joined the university back to 1976 after receiving his doctoral training in clinical psychology from the University of Oregon. He served as the director of clinical training of approved doctoral programs in clinical psychology, and also the co-director of the Center of Alcoholism, Substance Abuse, and Addictions. Professor Mueller has published 40 books, 40 books, and also over 400 articles and chapters. His interest is very much in the area of development, testing, dissemination of behavioral interventions for people affected by addiction. Finally, I just want to mention, apart from his teaching, clinical work, writing, Professor Mueller also served as the consultant to many organizations such as United States Senate, the World Health Organization, and the National Academy of Sciences, and the National Institute of Health. Lately, Professor Mueller is also interested in some pastoral counseling and the whole thing about integration, the intersection between psychology and also spirituality. Well, would you please join me to welcome Professor Muller.
Pleasure to be here. I've come 8,000 miles to tell you a story, really, which is the story of where motivational interviewing came from. And you might expect that a theory would begin with some sort of, a therapy would begin with some sort of theory. It's up a little bit. I see. There we go. And proceed logically through all sorts of careful steps. In fact, motivational interviewing emerged kind of accidentally. Can't hear very well. Someone have control of the sound there? All right. Not much I can do about it, but yeah. In fact, motivational interviewing arose kind of accidentally without a theoretical basis. And I want to describe to you some of the accidents by which that happened. The first one was that I was in a doctoral program that was very behavioral. We were to be behavior therapists. But there was a year-long practicum in the second year about how to talk to patients. And none of the behaviorists wanted to teach it. They weren't interested in that. And so they went over to the counseling department and found a faculty member there named Susan Gilmore, who was a student of Leona Tyler, who was a student of Carl Rogers. So we were being trained by a granddaughter of Carl Rogers academically. And that's what she taught us. She taught us a person-centered way of being with patients before I ever began to practice any behavior therapy, before we ever saw any patients, just by virtue of the fact that none of the behaviorists wanted to teach the course. I had a summer internship in Milwaukee, Wisconsin, and wound up working on the alcoholism treatment unit there because the director of the unit said, well, what do you know about alcoholism? And I said, nothing. He said, well, what did they tell you in your graduate courses? And I said, I don't remember it ever coming up. He said, well, you better come learn about this because it is the most common diagnosis that you will see for the rest of your life. So you better learn something about it. And all I knew was Carl Rogers. I just had the second year course. Something else? All right. All right. And so I simply sat down with the patients on the unit and put on my best Carl Rogers hat and listened well. And they seemed to enjoy the process, and I really did. I mean, I found I loved talking to people with alcohol and later on other drug problems. And it was a very enjoyable experience for both of us. And then I began to read the literature about alcoholism. And it said alcoholics are liars. They are in pathological denial. They're out of touch with reality. I said, well, those don't sound like the people I've been talking to. Maybe they're different in Milwaukee, I don't know, but they didn't seem to be that kind of person to me. So I had that puzzle of, why is the literature so negative about people with alcohol problems when my experience of listening to people was very positive and they were very open and telling me about how they got to this place in their life? Well, I went back and began to do research on alcohol problems, including my dissertation. And in one study, the control group, we forgot to tell them that they were the control group, and they got better. And we were trying to understand why that happened. We randomly assigned people to either receive counselor-delivered behavior therapy for 10 weeks to help them with their alcohol problems, or to get a single session of advice and be sent home with some self-help materials that eventually became this self-help book. But at that point, it was just a set of stapled papers. And what we found was, to our surprise and horror, both groups changed their drinking rather dramatically. And there was no significant difference between the two groups. That is, the decrease in alcohol use was the same. If anything, it was a little bit more for the self-directed group. Now, my question had been, how much better will people do when they're working with a therapist? And the answer was not at all. All the way out to 12-month follow-up, where the groups are quite identical. So what's going on there? You know? Well, I moved to, yes, of course. Now, using a lavalier now. I hope that's better. Okay. Okay, all right. So with that finding, I moved to New Mexico and thought it would go away. But in New Mexico, we actually replicated that 3 times in 1978, again in a clinical trial in 1979, again in a clinical trial in 1980. I was the one in denial, you know, and finally said, I think we have a finding here. I mean, I think three times in a row we've had very similar outcomes between people told that they can make this change on their own and given some instructions for doing so, and them coming in and working with a therapist. Well, maybe it's just the passage of time. Maybe it's just that if once you say, yes, I'd like some help with an alcohol problem, nothing else needs to be done. If the time passes, the people will get better. And the other thing was, we asked people what had helped them, and we were having them keep record cards of their drinking. And that was the most often mentioned thing, that really writing down every drink that I was having made me very conscious of it. I think that helped me. And so in the next study, we had a couple of control groups that were waiting list groups. One of them just waited for 10 weeks. The other one waited for 10 weeks and kept a diary. And then we had the same 2 groups as before, one seeing a therapist and one going home with a self-help book. And what happened was, again, got a very nice decrease in the group working on their own, and they wind up at the same place as those working with a therapist. But those on the waiting list don't move at all. And then their drinking comes down when we treat them. They saw a therapist, and splashes back a little bit, but that there was no change at all with just the passage of time and just keeping records. If anything, people's drinking went up just a little bit when they were keeping records, all the way out to 15 months. Well, what's going on? Well, now there are dozens of clinical trials in the literature showing that relatively brief interventions can help people to change their drinking, even a single session that has certain kinds of characteristics. We didn't know that at the time, but now it's well documented. And if that's so, if it's so easy, why didn't the waiting list get better? And then it struck me. They were doing what we told them to do. They were waiting. The message is, if you're on a waiting list, you're not expected to get any better until we can treat you, and then it'll be all right to get better. You know? And they very politely waited for us, and then we treated them, and then they got better. But the group that we told, you can do this on your own, here's some instructions, go home and follow these instructions, had a big reduction. You know? We have that kind of suggestive power just by what we tell people. It was striking to me. Something else I began to notice was that the outcome that clients had was very much a function of who treated them. So even though they were all receiving allegedly the same treatment, And this was manual guided treatment. We had a manual for what to do in each session and so forth. The outcomes were very different depending on who the counselor was. You can see how long ago we did this study. This is our staff, you know. I had two other supervisors besides myself and 9 therapists. And we were watching the therapist work through one-way mirrors. We could not afford video at that point, so we were watching them work through one-way mirrors. And we randomly assigned problem drinkers to therapists. And we were rating the therapists on how well they were listening to their patients using a scale developed by Carl Rogers' students, Truex and Kharkov. So the better you were listening to your clients and reflecting that understanding back to them, the higher your score. Well, so we did our ratings. We agreed with each other very highly about who was the most empathic and least empathic. And we lined the therapist up from the most empathic behavior therapist to the least empathic behavior therapist. And then we got our outcome data and said, well, how are their clients doing? And there was a very strong relationship. The most empathic therapist, 100% of her clients were doing significantly better. At the other end of the scale, a different therapist using the same manual guided treatment, who was not listening to patients very well, had a 25% success rate. And the correlation is pretty strong. And by the way, there was the group going home and working on their own. They had a 60% success rate. So if you average all the therapists together, you get a 61% success rate. You know? No different from self-help manuals. And you could conclude that, well, self-help manuals are no different from therapy. But you'd be wrong. Because 5 of these therapists, their clients are doing better than in the self-help condition. And there are 3 therapists where the clients would have been better off going home with a good book than working with this therapist, you know. And so allegedly all receiving the same treatment, how very different the outcomes were. Now that turns out to be the normal finding in addiction research and many other areas as well. We were able to predict 2/3 of the variance in how many drinks per week our clients would be having at 6 months. The correlation between therapist empathy and client drinking was a negative 0.82. That is, if you're listening well to your clients, they're not going to be drinking very much. If you're not a good listener, your client's going to be drinking a lot. We're still accounting 2 years later for 1/4 of the variance, which is still an awful lot in psychological research 2 years after treatment is over. Big effect. The next year, Steve Valley published a study. We didn't know each other at the time, but he was looking at relapse rates. So up is not good in this graph. People working with high empathy therapists, with medium empathy therapists, with low empathy therapists, all right? And the relapse rates are 2 to 4 times higher in the same treatment program if your therapist wasn't a very good listener, all right? Same finding. Well, I went off to Norway with these findings, with this striking effect of empathy in behavior therapy as the main thing that was driving outcomes. And I went to Norway to lecture on behavioral treatment of alcoholism. But the director of the clinic, this was an alcoholism clinic, said, well, would you be willing to meet with our psychologists every other week, every 2 weeks or so, and just have a discussion about treatment and whatever, and kind of teach them some skills. And I said, okay, I can do that. And I began teaching them both behavioral therapy and person-centered reflective listening. Good Carl Rogers, both things. And they really wanted me to demonstrate how I would be treating the patients that they were treating. Because many of these psychologists were pretty recently out of school, but they were treating pretty severely dependent people with severe alcohol dependence. And so they would role play in English, thank goodness, the patients that they were seeing, and essentially say, okay, smart guy, what would you do with this? You know, How would you respond to a patient who's doing this? And I would do my best to do what I was doing in Milwaukee, and they would stop me. Now, my own American students did not interrupt me when I was doing a demonstration, but the Norwegian psychologist did. When I'm in the middle of doing a role play with a client, they would stop me and say, now what are you thinking right now? Now, you asked the client a question, but you could have asked a lot of different questions. Why did you ask that question? You reflected something the client said. You've been teaching us how to do reflective listening. You reflected something the client said, but the client said a lot of things. Why did you reflect that? And in the process, they caused me to come up with some decision rules that I was using, of which I was not conscious, of which I was not aware. I was behaving in particular ways with clients that were kind of embarrassingly different from the lectures I was giving in the next room, you know, on behavioral treatment. And so there began to emerge this picture of a way of working with people, the essence of which is it should be the client and not me who's making the arguments for change. I'm not the person saying you have a problem and this is what you need to do. I'm listening to the client tell me what they think is wrong in their life and what they might want to do about it. And I'm evoking their own concerns. I'm not telling them why they should be concerned. I'm having them tell me what they're concerned about in their life and what's not going well. And listening with empathy, with this particular style of listening that Carl Rogers introduced in the 1950s. And if I'm meeting resistance, I'm never pushing back against it. I'm never confronting it. I'm never disagreeing and arguing with it. And in America at that time, treatment for addiction was very, very confrontational. Patients were being told to shut up, you don't know anything, you're out of touch with reality, you're in denial, I'm going to tell you what you need to do. You know? And so what I was doing was really very, very different from that, was being interested in the patient's own perspective and motivations. And of course, to nurture hope and optimism that it's possible to change. So I'm hearing why they would want to change, how they would do it, and encouraging them that it's entirely possible. And at the time, I was thinking, well, I gave it this name, motivational interviewing. Rather than motivational conversation, I almost called it motivational conversation. But in conversation, two people, you're just doing the same thing. In an interview, you have different responsibilities, and the interviewer is doing something different from what the interviewee is doing. And it's about motivation, so the name made sense. And I was thinking of this really as a preparation for treatment, not as a treatment itself, just as something that would kind of get you ready to make changes in treatment. Well, then I went back to New Mexico and began to think about if we wanted to test this thing. Oh, by the way, I sent this paper around to several colleagues just to say, what do you think about this? That's something Carl Rogers used to do. He called it a discussion paper. You know, we had these ideas coming out of our conversation. What do you think? And one of the people I sent it to was Ray Hodgson, a psychologist in Wales. And he said, I want to publish it in the journal Behavioral Psychotherapy. I said, Ray, he was the editor of the journal. I said, Ray, I just made it up. I don't have any data at all. He said, trust me, it's a good paper, let me publish it. So it did. I thought that was the last I would hear of it, published the paper. But we would say, well, if we wanted to evaluate this, what would it look like? And so I come up with something called the drinker's checkup that we meant to attract people at very early stages of developing drinking problems. So we just had ads in the newspaper. And we said we have a free checkup available for anyone who wonders whether alcohol might be harming them. You know? This is not a treatment program. You won't be labeled. You won't get a diagnosis. You'll just get some health information back, and what you do with that is up to you. You know? Whoops. Let's see. How do I escape from this? Like that. So we did a thorough assessment looking for things that get affected early by drinking Then we had one session with people giving them information about what we had found and listening to them. Not telling them what they should do, but just listening to their own responses to those things. And we called it the Drinker's Checkup. And then we gave them a list of all the treatment resources in town, the places they could go for treatment, thinking they would be more likely to go if they had the checkup. What we found was almost nobody went for treatment, but they had the nerve to change their drinking without getting permission from a therapist. You know? In fact, the change in drinking was very much like what we had been seeing in our previous studies. It was quite a large reduction in drinking, having received nothing more than the Drinker's Checkup. That's what came to be called motivational enhancement therapy, which is just a combination of motivational interviewing as a clinical style and assessment feedback, getting some information about yourself. We tried comparing two different counseling styles, a more confrontive, here's what it means and here's what you should do style, and a more motivational listening style. And we got a reduction in both, but a bigger reduction in the group getting the motivational interviewing style. And the waiting list, once again, very politely waited for us and did not get better. And then we gave them the Drinker's Checkup, and then they got better. You know, so we're seeing a pattern here. We also began to see that clients were doing something very differently depending which style the therapist was using. There was a directive style of kind of telling people what was wrong with them and giving them advice. And then this empathic style of listening to people and asking them about their perceptions of what needed to happen. And we found that in the listening condition, we were getting twice as much of what we now call change talk. That is the client making the arguments for change, saying, yes, I think this is a serious problem and I need to do something about it. Twice as much of that from clients being listened to rather than told. And then we also looked at resistance, and we got twice as much resistance in the group getting directive advice and half as much resistance in the group being listened to. And what we know now but didn't know at the time is that the ratio of change talk to resistance is what predicts change. So the bigger the difference between these two, the more likely it is that the person's actually going to make a change, in this case, in their drinking. Well, can you make that happen? Or is it just that motivated people get better? You know, well, imagine this. Imagine changing your counseling style every 12 minutes, right? And going back and forth between listening to people or teaching people, being directive and giving them advice, all right? So 12 minutes of one, 12 minutes of the other, 12 minutes of one, 12 minutes of the other. What happens to client resistance? This is a study by Jerry Patterson, 1985. Well, resistance goes up and down in a step function. You can control it just like the volume knob on a radio. You know? You can turn up client resistance, you can turn down client resistance. You turn it up by telling clients what's wrong with them and what to do, and you turn it down by listening to clients. All right? And we know that resistance predicts outcome. That is, high resistance predicts a bad outcome. Well, this is under therapist control. Well, with that, I went off to my second sabbatical in Australia, and I met this character named Steve Rolnick, who had the office next to mine at the National Drug and Alcohol Research Center. And he said, Miller, you the guy who wrote that paper on motivational interviewing? Well, I was impressed anybody had read it, you know. I said, wow, you read it? You know, what did you think? And he said, read it. I've been trying to teach this. This has become a preferred treatment for addiction in the United Kingdom, and I'm getting all these demands to learn it, and I don't even know if I'm doing it right. There's just this one little paper. I mean, you need to write more, you know. And so I said, well, show me what you do. And he had exactly the same heart and exactly the same idea and the same approach that I had. And so I said, look, why don't we write a book together? You know? And we did. And that's where the first edition of motivational interviewing came from, an accidental meeting in Australia between Miller and Rolnick, who, you know, I had some ideas about the treatment. He had great ideas about how to teach it. So we combined forces. That eventually became a second and a third edition of the book. Well, this has taken off like a rocket. This is a number of publications in Google Scholar with motivational interviewing in them per year and cumulative, and it's just skyrocketing. There are now over 80,000 publications about motivational interviewing. And if you think about the adoption curve for new interventions, if you know about this, like when a new computer comes out, a few people pick it up right away, but if it gets popular, then it gets really steep, and then a whole lot of people pick it up, and eventually it kind of levels off, and everybody who's ever going to adopt it has adopted it. Well, we're somewhere in the steep part of that curve right now, from what I can tell from publications. So where are we? Well, we've got motivational interviewing books translated in 27 languages. There are, as of this week, 1,100 controlled trials, clinical trials published in the literature on motivational interviewing, 20 multi-site trials, 80,000 publications across an amazing array of different problem areas. Now, I was just thinking about alcohol problems, but it quickly spread into other drug problems, then spread into healthcare. Why healthcare? Well, it's something to help people resolve ambivalence. If you get diagnosed with diabetes, as I was 13 years ago, you get a 90-minute lecture about the 11 changes you need to make in your life, and then just a huge amount of information, And you're kind of used to living your life the way you live it, and you're not sure you want to make all these changes, and most people with diabetes don't make those changes with serious consequences for their health. Well, here's an area where motivational interviewing seems to make a difference, particularly in chronic disease management. Then into corrections, then into social work, into dentistry more recently, just all sorts of areas where people need to make a change in order to be healthy, but tend not to do it. So if you work in one of those areas, here's the tool for you. We've now trained more than 3,000 trainers around the world, working in 54 different languages. So this has crossed cultures amazingly well and is being implemented at whole nation levels and whole state levels. So way past anything I dreamed of. So what is this thing? Well, just an everyday language definition is it's a way of having a conversation about change to strengthen the person's own motivation for and commitment to change. It's just a way of having this conversation so that person's own motivation grows. And if you're a practitioner, it's a person-centered way of counseling to deal with that common problem of ambivalence or reluctance to change. Now, Steve and I began teaching this in 1991 with our new book, and we started to see people practicing the techniques that we had taught them, and we were horrified. We didn't like what we saw. It was as if people were trying to use the techniques on people, pardon me, and trick them into changing or manipulate them into changing or whatever. I'm going to just outsmart you and make you change. And it just felt completely wrong, which wasn't their fault, it was our fault. There was something we had not taught them. There was something we had not included besides the techniques. And we began to call that the underlying spirit of motivational interviewing, the mindset and the heart set with which you practice this. And it matters. It matters. What is it? Well, first of all, it's collaborative. It's just a partnership. This is not an expert telling somebody what to do and what's wrong with them. This is two people, both of whom have expertise, having a conversation. I have some expertise on alcohol problems and behavior change, but who knows more about the client's life than the client does? And the person sitting across from me knows more about them than anybody else in the world does. And for change to fit into their life, I need their expertise. And so we're collaborating together to say, how might this work for you? Right? Compassion, sure, the reason that we're having this conversation is the other person's well-being. It's not about me. Evocation, I'm calling forth from clients what they already have. What a different model from my behavioral training. In my behavioral training, mostly the assumption was clients are having trouble because they lack something. You need to give them what they lack. Is it insight, maybe? Or rational thinking? Clients are irrational. I'm a rational thinker. I'll give you rational thinking, you know. Or you lack a skill, and I'll give you a skill, and then you'll be better. You know, it's that deficit kind of model. The message behind which is, I have what you need, and I'll give it to you. You know? In motivational interviewing, the message is, you have what you need, and together we're going to find it. Very different kind of approach. So it's evoking what's already there, the client's own wisdom, the client's own motivation, rather than imagining that you're installing something that the client lacks. And then profound, radical acceptance of people as they are. One of Carl Rogers' insights is that when you feel unacceptable, it's almost impossible to change. When you experience yourself as being unacceptable, it's very difficult to change. And it is when you experience yourself being accepted as you are, it becomes possible to change. Now, I don't know why we are wired that way, but we seem to be. That if you make people feel unacceptable, ashamed, embarrassed, and humiliated, they're very unlikely to change. If you cause people to feel empowered and hopeful and able to change and strong, having strengths in themselves, they're more likely to change. And so that kind of radical acceptance as you are, you know, along with which goes the knowledge that people get to make decisions about themselves. I don't get to choose whether somebody's going to change their behavior or not. My clients get to do that. And it's freeing to realize that, actually. I can't make somebody change. You know? Can have a conversation with them about it, but it really is up to them. Right? Well, now we talk about 4 processes behind motivational interviewing. I think it's a more helpful way of talking about and understanding what we're doing than previous approaches we had in the first 2 editions. And they are these, and they're sort of like stair steps. First is engaging. It's forming a relationship with the person, a trusting relationship, so that they feel safe. And you do that primarily by what Carl Rogers taught us to do, which is listening well and being interested in the person's own perspectives. And that's a foundation on which everything else in motivational interviewing is built. Until reflective listening gets fairly easy for you, it's hard to do the rest of motivational interviewing. But when you have that, you've got a really big head start on motivational interviewing. Well, besides listening well and forming a good therapeutic relationship, what else is there? Well, next there is finding your focus. What are the goals? Where are we going? The question on the bottom step here is, can we walk together? Can we take a journey together? Will you trust me to walk with you? Here the question is, where are we going? What do we want to get to? With that in place, you next ask, why would you want to go there? You begin doing what's unique to motivational interviewing, which is evoking the person's own motivations for change. And then and only then do you begin to talk about how to change. Because until the person wants to do it, until the person feels motivated to do it, it doesn't matter if you're talking about how, because they're not too interested in that. Now, I don't know about your country, but in my country, very often the very first session of mental health or addiction counseling goes straight to planning. Here's what we're going to have: a treatment plan at the end of the first session, you know, and we're going to decide what you're going to do. You know, missing everything else, missing forming a therapeutic relationship, missing getting clear on what goals there are on the person's own interests. You know, it just doesn't work as well. You know, we have this idea that what you have to do in the first session is collect a lot of facts, a lot of information. Well, that's not helpful to the client. You know? In fact, it implies once I know enough facts, I'll be able to fix you, which is not true. Yeah. We've learned an awful lot about language, and we pay a lot of attention to client speech. And what I was telling you about change talk these are some of the categories of change talk. People say, well, I want to stop smoking. That's an expression of desire. You know, I wish I could stop smoking. I would like to stop smoking. You know, that's one kind of change talk language. There's ability language. I could stop smoking. I think I could. I don't want to, but I could. See, they're different. Yeah. There's reasons. Well, my kids would be happy if I stopped smoking. They're always saying, "Please, Daddy, please stop smoking." You know. And I know that they'd be happy if I did that. And I'd probably have more money to spend if I weren't buying cigarettes all the time. Need statements. I've got to do something about my smoking. I really have to quit. You know. All of that we call preparatory. It's kind of getting ready to change. You're talking yourself into change, which really is what's going on in motivational interviewing. You're helping people talk themselves into changing. Over here, you've got commitment. I will stop smoking. You know, I plan to stop smoking. You know. Or almost commitment. I'm willing to think about stopping smoking. You know, I think I'm ready to stop smoking. You know. And then just doing things, you know, that are steps in the right direction. I filled that prescription you gave me. You know, well, that's doing something that's moving in the right direction. The other side of the coin we call sustained talk, and that's all the arguments against change. And people who are ambivalent will give you both. They'll tell you reasons to change and reasons not to change. You know? But if you argue why they should change, they'll tell you why they shouldn't. You know? And you're literally helping them talk themselves out of changing. It's one of the things we've learned. All right. Well, the first couple of editions of Motivational Interviewing, we were a little uncomfortable with this concept of resistance because it kind of sounds like you're blaming the person for not getting better. And that's not right, you know. But it's like either, you know, here I am, this perfectly good therapist, telling you what you need to do, and you're just not cooperating, you know. I mean, that's kind of one sense of resistance. Or there's something wrong with you, you're in denial, and that's why you're not getting better. But in both cases, you're blaming the client for not getting better. Well, an awful lot of what we think of as resistance is just sustained talk. It's just the person's arguments against change, which is only one half of their ambivalence. Right? But then there's something else that we call discord, which is communications that I'm not comfortable right now in our relationship. And these things tend to have the word you in them. You don't understand me. You don't know how hard this is, you know. You're not listening to me, you know. Both of those things predict a lack of change. So it matters how you respond to them, and I showed you, you can drive that up and down. I can teach you how to have really, really resistive clients. It's not that hard. Tell them what's wrong with them and tell them what to do. Yeah. All right. Well, to kind of start wrapping up, what do we know about this? Because now there's an enormous amount of research out there on motivational interviewing. So, okay, I've given you some ideas, and maybe those are just my ideas. But what do we know about this scientifically? So here are the things that we know so far. First of all, we know that this can be used in a lot of different contexts. It's been tested in healthcare and corrections and social work and dentistry, in physical therapy and occupational therapy. I mean, almost regardless of the problem area you're dealing with, there have been studies about this. And the findings have implications. And the implication here is that this can be applied a whole lot more broadly than we knew in the first place. The first book was just about addictions. The second edition was about change, more generally. So we learned this is not just addictions. This is more like something about human nature that can be applied broadly. Second thing we learned is that this can work in pretty brief formats. It doesn't take a long time. My surprise, you know, one session and give people some materials to take home, and they're improving just as much as people getting 10 sessions of therapy. It's now being used in healthcare, and doctors don't have a whole lot of time to talk to patients. but even in relatively short periods of time, you can have this kind of conversation in a way that makes a difference. So it's something that doesn't have to take a long time. Implication of that, this motivational interviewing, unlike my initial expectation, can be a freestanding intervention. It's something you can do by itself that may very well have a beneficial impact, even if you don't have very long. That was something new we learned. I didn't expect that. Third thing we've learned is people can learn how to do this. You can get better with practice. You can get better with feedback and coaching. You can develop these skills. But the implication that we found is learning this is not really simple. You can't read about it and be pretty good at it. You can't come to a 2-day workshop with me and at the end of that be good at it. That's just a beginning of your learning. It's a process that's learned over time, like a sport, like a musical instrument, where you have someone who's better at it than you are, giving you some suggestions along the way. Now that's how we learn any complex skill. And I don't know why we ever thought that coming to a workshop would change practice behavior. It doesn't, It takes a little more than that. So we've learned a lot out of that as well. We've learned that the effectiveness is highly variable. About 2/3 of published studies find a significant effect of motivational interviewing. About 1/3 of them don't. So there are studies out there saying no effect of motivational interviewing, including one that I published. So why is that? Sometimes it works, sometimes it doesn't. Therapists matter a lot. You saw that. Some therapists are just a whole lot better at this than other people are. And how well the client does depends on the therapist they happen to get assigned to. And the more empathic the therapist, the better the outcome. There are at least 20 multi-site studies of motivational interviewing, and a normal finding is motivational interviewing worked at some sites and not others. At some cities, it had a significant effect. In other cities, it didn't. Of course, there are different therapists in different cities too, and there are all kinds of other things going on. But there's something about it that you need to understand to know why it's working. That is, we need some good process research to tell us when does it work and why does it work and how come it doesn't work sometimes. Right? Well, one thing we know is the better the quality of motivational interviewing that's being delivered, the better the outcome is. Not always, not every study finds that, but most studies do find that. That the better the quality of motivational interviewing, which is measurable, reliably measurable, the better clients tend to do. And by the way, there are also big differences within therapists, because I'm better at this some days than I am other days. So how well I'm doing it on one day versus another day predicts how my clients are going to do. This is sobering stuff. I mean, I got to pay attention when I'm sitting down with clients and really be mindful of what I'm doing. Implication? We need to focus more on the technical as well as the relational skills in motivational training. It's not just a matter of being nice to people. By itself, that's not enough. We know, as I told you, that we can predict from what a client says during the session whether they're going to change. The more change talk and the less resistance there is, the more likely the person is actually going to change. And it's the ratio of those two, better than either one of them individually. And by the way, therapists have a substantial impact on both change talk and resistance. You can drive them both up and down. Implication? One important thing is to stop doing the wrong things. In fact, sometimes I think that's the main impact of MI training. You just stop telling people what to do and telling them what's wrong with them, and they're more likely to get better. So not doing things that cause your client to be resistive is important. When MI is compared with other treatments, usually other treatments that are a lot longer, the outcomes tend to be the same. So you have a direct head-to-head horse race comparison of motivational interviewing versus cognitive behavior therapy, the outcomes are the same. Even though cognitive behavior therapy may be 3 times longer, on average, the outcome is the same. Well, one implication of that is that people are now using motivational interviewing as a kind of minimal treatment control. If you can't do better than that with your medication or with your behavior therapy, then why not just do motivational interviewing? So it's something that you can do in a relatively short period of time that's unlikely to hurt anybody and is likely to help people. In other words, if you only have 1 session with people, do a motivational interview, because you've done something that is likely to help them whether or not they come back, which often in addiction treatment they don't. When you add motivational interviewing to other treatments, they both work better. Now that's interesting. You have an active treatment like nicotine substitution, or cognitive therapy for depression. We know these things have an impact of their own. But when you add motivational interviewing to it, the therapy works better. Why? Because people are more likely to stay in treatment, first of all. They're more likely to take their medication or to do the things they need to do to get better. And so the treatment works better. Motivational interviewing has its own benefit, plus it has the benefit of there's another active treatment helping the person as well. So you get bigger treatment effects and they last longer over time. Implication. Now motivational interviewing is usually being used along with other things. There aren't so many studies anymore of just motivational interviewing. Lots and lots of studies are, we used motivational interviewing and this to try to affect this problem. And that makes sense, much more than a horse race of which is better, motivational interviewing or something else. Because this is a clinical style. I've been saying motivational interviewing is a way of doing what else you do. It's a way of doing what else you do. And by the way, the things that predict good outcomes in motivational interviewing also predict good outcomes in behavior therapy, also predict good outcomes in cognitive therapy, in group therapy, in healthcare, with acupuncture. In other words, the same kinds of therapists tend to have good outcomes across a whole variety of different kinds of treatment. And they are the very kinds of things that we've been training in motivational interviewing. So in a way, maybe we haven't even been developing a different treatment. Maybe we've been discovering what it is that makes an effective therapist. Maybe that's what we've been studying all this time. Not something completely separate and different from what you do, but how to do what you do and have better outcomes. And what predicts success with motivational interviewing? Well, clients who are less motivated, this tends to be really good. If they don't come in wanting to change, this is much better than behavior therapy telling them what to do. If they come in angry and resistive and they don't want to be there, somebody forced them to come, this is way better than a directive, prescriptive kind of therapy. Clients who are already ready for change don't need the evoking elements of motivational interviewing. They're ready for planning. So you just go to the planning process. And then if you run into trouble, you can back up and do motivational interviewing if you need to. All right. So not everybody needs motivational interviewing. That's the kind of the bottom line on that one. It's particularly useful for people who are ambivalent, who are resistive, who are not sure they want to make a change, who are angry at you, who are defensive, who seem to be unmotivated. People who particularly benefit. This crosses cultures well. I told you it's being practiced and taught in 54 languages now. There are clinical trials coming off of every continent except Antarctica. We don't have any motivational interviewers down there yet. But controlled trials coming from Arabic nations, from Oceania, from Europe, from Asia, from North and South America, all over the place. And we found, interestingly, in the United States that the effect size of motivational interviewing was bigger with minority clients than with people with a white skin like me. That is, the people being treated by white therapists are African American or Asian American, they get twice the benefit that white clients do. Now, isn't that interesting? I would have been happy if it was the same, that minority clients benefit just as much as other people do. They benefit twice as much. That's pretty interesting. And it kind of fits with something else, which motivational interviewing seems to particularly benefit people and groups who are disrespected, who are disenfranchised, who are pushed out of society and marginalized, you know, the homeless, people with HIV, you know, sex workers, people who are seen as not us, you know. The effect is particularly strong if you work with these populations. And maybe it's rooted in something about us as human beings. I think it is. There's a wonderful paper by an evolutionary psychologist last year that I think has some real clues about why this is working. So what do we got? We have 4 decades of research. Well, we have a treatment now that has a good evidence base. I mean, 1,100 clinical trials. That's a lot of evidence base. That's relatively short. We're not talking long-term psychotherapy here. We're talking about something that can be done within a relatively short space of time. We can teach you how to do it. It's specifiable. These are the things you do. But we've learned to be careful with manuals because therapists working with manuals are less effective than therapists doing this without a manual in front of them. Now, why is that? If you're paying more attention to your manual than to your client, you're not doing it right. You know? Manuals are too restrictive. We can listen to tapes and 2 different coders can agree how good it is, what's the quality of motivational interviewing. So we have great fidelity measures now. We understand something about why this works. Change talk is important, resistance is important, empathy is important. So we can predict from things that are happening during the session how it's going. Just crosses an amazing array of clinical problems, just all sorts of things. Culturally adaptable. Very good in counseling cross-culturally, I think, in counseling people who are very different from yourself. It's not something you have to be converted to and give up what else you do and stop doing that and start doing motivational interviewing. This is complementary to what you do. As I said, it's a way of doing what you do. And putting them together makes sense. And it's learnable by a broad range of providers. We have found no relationship between the number of years of education and the ability to learn motivational interviewing. It's just kind of something about human nature that we kind of can get this. You know? And even with all that, with 40 years, my sense is we're just beginning to understand what we're doing here. It's pretty exciting what we have so far, but we have a whole lot more to learn. And I can't wait to see what we learn next. This is our website. More than you want to know about motivational interviewing is available there. And that's my overview of about 40 years of work in less than an hour. So thank you very much. Shall we sit down here? Okay.
Professor, I need to get back your clip. Thank you. Thank you.
Thank you so much, Bill, if I may.
Yes, please.
I feel absolutely humble with your last remark by saying we are just at the beginning. 40 years work in psychosocial intervention is massive. So I mean, even that remark teaches me a lot, I would say. Okay, guys, what we have here is a whole list of questions and also voting as well. Surprise, surprise, my testing trial get most likes, okay? So it's a good start. People are super motivated to vote my liking trial. Apart from that, we do have some questions here to begin with. I mean, guys, time is so precious. You're so motivated to come. Congratulations, and I'm sure, like myself, we learn a lot. But I think this dialogue is also very important. I would suggest we begin with a couple of questions from the from the polling here, and then I will open up, and so it would be very, very helpful if you have other questions, so we can enter indeed a dialogue. So, Bill, the first question to begin with here by saying, I think you can make some brief comments. Can a person be both therapist and the client? Can MI be used in self-help, self-talk fashion?
The answer is I don't know.
Right. I thought you would say yes, yes, and yes.
We haven't done the science on that. There is a self-help book written by Alan Zukoff, using what we've learned in a kind of follow these steps. We don't have outcome data with it so far. So is this something you can do for yourself? Probably. But I don't have the good solid science to say, oh yeah, this is a great self-help thing. We don't know.
Mm-hmm. Okay, so sticking to the science. Another high voting question here is motivational interviewing restricted to one-to-one session? Can it be done in group session, and how? Any thought on that?
Oh yes, a lot. Well, not only thought, but a lot of research on motivational interviewing being done in group settings. So this can be done with multiple clients at the same time. It's good to learn how to do this with one client at a time first, because it's more complicated to walk into a group and do this. But you're really doing the same kinds of things. You're listening well, you're reflecting what people are saying, you're calling forth change talk, you're intentionally doing things in group to have as many people talking about their reasons for change as possible, and you respond to resistance or sustained talk in a way that doesn't make it worse, that calms it down. There's a very good book by Chris Wagner and Karen Ingersoll on motivational interviewing in groups. So they've learned a lot about how to do this in a group format, and it can be done.
So group format can be done.
Mm-hmm.
Yeah,
Yes.
I've seen work being done, for example, in commercial sector, growing the motivation as a group, meeting work target and so forth. I mean, as another example. Well, I think we got another good question here. After this one, I'd like to open to the audience, because I think one of the features of motivational interviewing is to have option. Not everyone wants to type with the electronic device. Some of you would like to speak up. Please do that. A good question here, Bill. How would you comment on the relationship between MI and also stages of change? For example, we will change according to certain distinct stages of change.
Yeah. What I say about trans-theoretical model and motivational interviewing is that we grew up together in the late 1980s, or actually early 1980s. Jim Prochaska and Carlo Di Clemente were developing the trans-theoretical model, which is much bigger than the stages of change, by the way. At the same time, we were developing motivational interviewing, and they kind of fit together. I mean, because motivational interviewing was something that you can do with people who are in the pre-contemplation stage, or the contemplation stage, or the preparation stage, to help bring them around to action. Now, my training as a behaviorist, I knew what to do when the client's in the action stage, but if they weren't there yet, I didn't know what to do. Well, motivational interviewing is something you can do. And so Carlo and Jim began using motivational interviewing as an example of, if someone's in contemplation, this is what they need. If they're in the action stage, maybe they need behavior therapy or something else. But they started getting confused with each other as well. And if you've looked at all three of the editions, we began to back away from the trans-theoretical model in the second edition because we saw things like clients being given a lecture on the stages of change, and that was called motivational interviewing. You know. So they just got too confused. In third edition, we're kind of coming back to how they fit together again, but they're not the same thing. Motivational interviewing is not a theory about why people change and how they change, whereas the trans-theoretical model is. Trans-theoretical model itself didn't really produce too much in the way of interventions. Motivational interviewing is an intervention. So they make sense together. And what I say now is that, if this makes any sense, they're kissing cousins who never married. You know, that's yeah.
Yeah, I like it. Okay, any questions, comments from the floor? Please, anyone would like to? Right, thank you.
Thank you very much for your sharing. Very interesting. The question I'd like to ask is, what other areas in MI you are exploring further for the future?
Myself, I'm retired. So, but what's happening is astonishing. I mean, I do keep up with clinical trials, which is how I know there are 1,100 of them. And they're just popping up in all kinds of areas. I just saw one this week on using motivational interviewing to help encourage families to accept an autopsy where it's needed. I would never have thought of that, you know. It's financial planning is a place where, you know, helping people to manage their spending.
Financial planning. Mm-hmm.
I mean, these are areas that never occurred to me. I had not thought of dentistry, but it makes perfect sense in dentistry. I mean, if you floss your teeth and brush your teeth, you'll keep your teeth, first of all, and your mouth will be healthier. But now we know that's also important for cardiovascular health.
Yes.
And so there are really good reasons to do that. How do you get people to floss their teeth and brush their teeth when they're not doing it? Well, here's a method, you know, and it looks like it works. So I never know where it's going next. It's fascinating. But it just keeps being applied in new areas all the time. Yeah.
Thank you. Questions?
Obviously, a therapist is very important in MI. Does the spiritual orientation of a therapist count, or have there been any kind of studies on this area?
We've never evaluated the spiritual orientation of therapists. I mean, there is research on that with cognitive therapy, for example, and it doesn't seem to impact there. It's more what you do and how you're doing it, rather than what your personal belief system is, you know. But we've not looked specifically at that with motivational interviewing. I mean, to me, it's very compatible with my own spirituality, but that's not something that somebody else has to share in order to be able to do motivational interviewing.
So you're saying it comes down to how a therapist does what he or she does.
That's right.
With regard to the spiritual belief.
That's what matters.
Yeah, okay, maybe another one or two comments. Yeah, thank you.
Thank you so much, Professor Miller. Now, since listening is so central to the whole process, but listening is also a process of, for example, cultivating listening. Now, these two types of therapists that you mentioned, you know, the directive and the more empathetic. So how the process of listening becomes a process of cultivation and mutual cultivation. The second query is that there is, even if you listen, there might be still some disjunction. And maybe we would like to listen to that even if you are an empathetic listener, and there still might be a disjunction in communication between, and so how do we integrate the reality of disjunction and divergence in this art of communication? And finally, about personal, and since you mentioned about person-centered, therapy, And here in terms of resources, along with Carl Rogers, whether you also felt inspired in engaging with Martin Buber and the whole idea of personal and the transpersonal. And in the related field, there is a lot of, attention to Thich Nhat Hanh, his idea of attention and attentiveness, and whether there is a kind of an ecology of spirit in terms of putting motivational interview along with these kinds of related, movements of thinking and practice.
Well, that's quite a lot. I want to be modest about that. This is a measurable and learnable skill,
Listening.
Listening. This particular kind of listening that Rogers defined, and his own students showed you can develop this, you can get better at this, and it matters, So I don't think you have to generalize beyond that to say this is something that people can learn to do, and it seems to benefit change. Now, when you listen to people, of course there are disjunctions. I mean, of course there are places where you're not in agreement or you don't see things the same way. I've been interested lately in my own country in teaching empathic listening to have people who are Republicans and Democrats talk to each other, because at the moment we are so polarized that if you're from the other party, the other team, then I won't talk to you. Well, it doesn't have to be that way. You can listen to someone who really has a very different viewpoint, and I think that can have a very beneficial outcome. So it doesn't mean you have to agree for there to be a healing component involved in listening. The third one, if I understood it, I'm certainly interested in the connections of listening with much larger understandings. You may know that Carl Rogers had dialogues with Martin Buber and with Paul Tillich, and they're very interesting to read those. I think if he were alive now, he'd be having a dialogue with the Dalai Lama, because there's an awful lot of Buddhism in this way of of being with people and listening and honoring their own perspective as well. So for me, it fits with these larger understandings, but you don't have to have those in order to be able to do this. It's a learnable skill that kind of teaches you acceptance in a way. And Rogers thought that was the case, that as you learn to extend acceptance to other people, you become more accepting of your own experience. And as you become more accepting of your own experience, it becomes possible to extend that acceptance to other people. So there is a self-development process in this that we know less about, but it's very clear to me that learning this changes you. Learning this does something to you. Yeah.
Okay, I wonder whether there is one last question from the floor. Yeah, thank you.
Yes.
Professor Rhythm, it would be nice if you should share with us more about. I have come across some client. He or she told me that he want to have some changes, but on and off in the coaching sessions, he or she will keep on complaining. Can you share me or with us more about how can we tackle, apart from the steps you just mentioned, engaging, focusing, evoking, planning, and then can you share more about how can we apply? Of course, I knew that if I can find more answer in buying your books, but in this short session, I would like you to share more about with us. Thank you.
I can save you some money here. The first thing that occurs to me is to listen reflectively to what the person is saying. If a person's complaining, that is talking about how difficult something is, and you don't listen well to it, they will keep complaining. If a client continues to repeat something, what they're telling you is, I don't think you heard this. Mm-hmm. I don't think you understand this. And so if you're hearing something come back again and again and again, stop and say, okay, I get it. This is really hard for you. You're really struggling with this, And it just kind of calms things down. It's if the person doesn't think you understand them, that they'll keep saying it over and over and over again. I think of there's a videotape of me talking to a man who was referred to me by his therapist to talk about his drinking, and he did not want to talk about his drinking. He came in, actually one of the first things he said was, "I think my real problem is smoking," you know. Well, that's not change talk about drinking, and I listened to that, but nonetheless, I was trying to move toward drinking. And he said, "But smoking's my real problem. I don't really have a problem with alcohol." So I just reflected what he said, which is, so alcohol really hasn't caused any problems for you. He said, "Well, no, anybody drinks as much as I do is going to have problems with it." Yeah. By listening to what he said, he gave me the other side of his ambivalence. He knows, you know, he knows he drinks too much. But if I tell him he drinks too much, he'll say, "I don't drink that much," you know. And if I say, "You need to change," he'll say, "No, I don't," you know. And I'm causing him to say all the wrong things, you know. If I'm arguing for change and the client's arguing against change, we need to swap chairs. Yeah. Yeah.
Thank you very much. I think it is a good place to stop here. I think we begin with a story, beginning with a story about people, and then I love that question about real client and also what we can do. Professor Mueller, thank you so much for your time. I think this evening you spoke with your gentle voice, but the substance, the content, the thinking, the invitation to think about listening, I think they command our attention. Not only for tonight, I think much more to think. And I remember back Claude Roger in his 70s, I think one time he said, at the age of 70, Claude Roger still talk about, "I'm learning to listen."
Oh, yes.
So it's so amazing. Shall we put our hands together to thank our speaker this morning, this evening, I should say. Two things here. That question is a lovely way to bring it closer to the meeting, but also reminds me this evening distinguished lecture was organized jointly with the Faculty of Social Sciences and also the Chinese Association Motivational Interviewing. So buying the book, talking to the founding author, and also getting in touch with the local association would be a very good way to learn, okay? So thank you again for your coming, and if you like, you can stay, and we still have some time before our dinner catching up. So again, thank you for your coming. Thank you.好多 question 啊，其實佢答得好正，所以真係整多2個鐘呢啲。係啊。哦，問佢啊，問佢啊，問佢啊。